Varcarolis, Foundations of Psychiatric Mental Health Nursing, 8th edition, Chapter 12, Schizophrenia Spectrum Disorders. Schizophrenia spectrum disorders are disorders that share features with schizophrenia. These disorders are characterized by psychosis, which refers to altered cognition, altered perception, and/or an impaired ability to determine what is real or not real. This chapter begins with an overview of schizophrenia spectrum disorders and then focuses on schizophrenia and associated nursing care. Delusional disorder. Delusional disorder is characterized by delusions that have lasted 1 month or longer. The delusions tend to have a general theme that includes grandiose, persecutory, somatic, and referential delusions. These delusions are usually not severe enough to impair occupational or daily functioning. Individuals with this personality disorder do not tend to behave strangely or bizarrely. The lifetime prevalence of delusional disorder is fairly low, at 0.2%. Brief psychotic disorder. Brief psychotic disorder is characterized by the sudden onset of at least one of the following: delusions, hallucinations, disorganized speech, and disorganized or catatonic, severely decreased motor activity, behavior. The symptoms must last longer than 1 day, but no longer than 1 month, with the exception of a return to normal functioning. Brief psychotic disorder accounts for about 9% of all first-time psychoses and is twice as common in females. Schizophreniform disorder. The essential features of this disorder are exactly like those of schizophrenia, except that symptoms last a much shorter period of time, less than 6 months. Also, impaired social or occupational functioning during some part of the illness is not apparent, although it might occur. It is difficult to know the prognosis of a schizophreniform disorder because some individuals return to their previous level of functioning, while others have more difficulties in moving forward. Schizoaffective disorder. This disorder is characterized by an uninterrupted period of illness during which there is a major depressive, manic, or mixed episode, concurrent with symptoms that meet the criteria for schizophrenia. The symptoms must not be caused by any substance use or abuse or general medical condition. It is about 1/3 as common as schizophrenia, with a lifetime prevalence of 0.3%. Substance-induced psychotic disorder and psychotic disorder due to another medical condition. Substances such as drugs, alcohol, medications, or toxin exposure can induce delusions and/or hallucinations. Hallucinations or delusions can also be caused by general medical conditions such as delirium, neurological problems, alterations, hepatic or renal diseases, and many more. Substance use and medical conditions should always be ruled out before a primary diagnosis of schizophrenia or other psychotic disorder is made. Schizophrenia. Clinical picture. In about 75% of those with schizophrenia, the disorder develops gradually, usually presenting between 15 and 25 years of age. However, there are also child onset before 15 years and late onset after 40 years forms as well. People who later develop schizophrenia often experience a prodromal phase, during which some milder symptoms of the disorder develop, often months or years before the disorder becomes fully apparent. During the prodromal phase, the person may do less well in school than his or her peers, be less socially engaged or adept, and demonstrate memory impairment, suspiciousness, and/or disorganization or oddities in speech or thought. All people diagnosed with schizophrenia have at least one psychotic symptom, such as hallucinations, delusions, and/or disorganized speech or thought. The symptoms are severe enough to disrupt normal activities such as school, work, family, and social interaction, and self-care. In children and young adults, they often delay or halt achievement of age-appropriate milestones. Basic needs such as hygiene, nutrition, and healthcare are often neglected, and socialization and relationships are often disrupted. The full criteria for schizophrenia are listed in the DSM-5 box. DSM-5 criteria for schizophrenia. A. 2 or more of the following, each present for a significant portion of time during a 1-month period, or less if successfully treated. At least one of these must be 1, 2, or 3. 1. Delusions. 2. Hallucinations. 3. Disorganized speech, e.g., frequent derailment or incoherence. 4. Grossly disorganized or catatonic behavior. 5. Negative symptoms, i.e., diminished emotional expression or abolition. B. For a significant portion of the time since the onset of the disturbance, level of functioning in one or more major areas, such as work, interpersonal relations, or self-care, is markedly below the level achieved before the onset, or when the onset is in childhood or adolescence, there's a failure to achieve expected levels of interpersonal, academic, or occupational functioning. C. Continuous signs of the disturbance persist for at least 6 months. This 6-month period must include at least 1 month of symptoms, or less if successfully treated, that meet criterion A, i.e. active phase symptoms, and may include periods of prodromal or residual symptoms. During these prodromal or residual periods, the signs of the disturbance may be manifested by only negative symptoms, or by 2 or more symptoms listed in criterion A, present in an attenuated form, e.g., odd beliefs, unusual perceptual experiences. D. Schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out because either 1. No major depressive or manic episodes have occurred concurrently with the active phase symptoms, or 2. If mood episodes have occurred during active phase symptoms, they have been present for a minority of the total duration of the active and residual periods of the illness. E. The disturbance is not attributable to the physiological effects of a substance, e.g., a drug of abuse, a medication, or another medical condition. F. If there is a history of autism spectrum disorder or a communication disorder of childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations, in addition to the other required symptoms of schizophrenia, are also present for at least 1 month, or less if successfully treated. Specify if the following core specifiers are only to be used after 1 year duration of the disorder and if they are not in contradiction to the diagnostic course criteria. First episode, currently an acute episode. First manifestation of the disorder, meeting the defining diagnostic symptom and time criteria. An acute episode is a time period in which the symptom criteria are fulfilled. First episode, currently in partial remission. Partial remission is a period of time during which an improvement after a previous episode is maintained and in which the defining criteria of the disorder are only partially fulfilled. First episode, currently in full remission. Full remission is a period of time after previous episode during which no disorder-specific symptoms are present. Multiple episodes, currently an acute episode. Multiple episodes may be determined after a minimum of 2 episodes, i.e. after a first episode, a remission, and a minimum of 1 relapse. Multiple episodes currently in partial remission. Multiple episodes currently in full remission. Continuous. Symptoms fulfilling the diagnostic symptom criteria of the disorder are remaining for the majority of the illness course, with sub-threshold symptom periods being very brief relative to the overall course. Unspecified. Specify if with catatonia. Specify current severity. Severity is rated by a quantitative assessment of the primary symptoms of psychosis, including delusions, hallucinations, disorganized speech, abnormal psychomotor behavior, and negative symptoms. Each of these symptoms may be rated for its current severity, most severe in the last 7 days, on a 5-point scale ranging from 0, not present, to 4, present and severe. Epidemiology. The prevalence of childhood-onset schizophrenia is about 1 in 40,000 children. It affects individuals of all races and cultures equally. It is diagnosed more frequently in males, 1.4 to 1, and among individuals growing up in urban areas. Onset in males is usually between the ages of 15 and 25 years and is associated with poorer functioning and more structural abnormality in the brain. The onset tends to be somewhat later in women, ages 25 to 35 years, who tend to have a better prognosis and experience less structural changes in the brain. Comorbidity. Substance use disorders, particularly alcohol and marijuana, occur in nearly half of affected individuals. Substance use is associated with higher rates of treatment non-adherence, relapse, incarceration, homelessness, violence, suicide, and a poorer prognosis. About 60% of individuals with schizophrenia use nicotine, possibly due to genetically mediated causes or as a form of coping with cognitive impairment or anxiety. Smoking doubles the risk of cancer and contributes to cardiovascular and respiratory disorders. Anxiety, depression, and suicide co-occur frequently in schizophrenia. At least 20% of people with schizophrenia attempt suicide, while 5 to 10% die by suicide, a rate 5 times that of the general population. Suicide attempts are more common within 3 years of diagnosis, and especially upon discharge after the first episode of the schizophrenia, but can occur at any point in the illness. Physical illnesses are more common among people with schizophrenia than in the general population. The risk of premature death due to medical illnesses is 3.5 times greater than that in the general population, and on average, patients with schizophrenia die more than 20 years prematurely. Individuals with psychotic disorders may be at greater risk of poor health, maintenance behaviors, poor nutrition, substance use, medication effects, poverty, limited access to health care, and reduced ability to recognize a response to signs of illness. They may also receive poor quality health care due to poverty, stigma, impaired ability to express their needs, or stereotyping, e.g. emergency room staff, assuming that chest pain is imaginary or not serious. Polydipsia is compulsive drinking of excess fluids. It occurs in up to 20% of individuals with schizophrenia and causes hyponatremia, also known as water intoxication, in 2% to 5%. Symptoms include confusion, delirium, hallucinations, worsening of existing psychotic symptoms, and ultimately coma. Contributing factors include antipsychotic medication, causes dry mouth, compulsive behavior, present in some with schizophrenia, and neuroendocrine abnormalities. Goldman, 2009. One should consider the possibility of hyponatremia when there is a sudden increase in psychotic symptoms, particularly if delirium, e.g. disorientation, restlessness, fluctuating vital signs, is also present. Risk factors. What has traditionally been called schizophrenia is now believed to be a group of disorders with common overlapping etiologies. People with schizophrenia demonstrate differences in brain chemistry, structure, and neurotransmission. This variation in etiologies makes it difficult to identify reliable neurostructural or neurochemical variations that could be used to identify individuals at high risk for developing schizophrenia. The diathesis stress model is probably the best explanation for the existence of this disorder. Schizophrenia occurs when multiple inherited gene abnormalities combine with non-genetic factors. These factors include viral infections, birth injuries, environmental stressors, prenatal malnutrition, and abnormal neural pruning that alters brain development or function and or injure the brain directly. Biological factors. Genetic. Schizophrenia spectrum disorders are inherited. About 80% of the risk of schizophrenia comes from genetic and epigenetic factors, factors such as toxins or psychological trauma that affect the expression of genes. Over 100 loci in the human genome are associated with an increased risk of schizophrenia. Concordance rates, i.e. the percentage of shared disorder in twins, are about 50% for identical twins and about 15% for fraternal twins. Evidence suggests that multiple genes on different chromosomes interact with one another in complex ways to create vulnerability for schizophrenia. Neurobiological. Dopamine theory. The first antipsychotic drugs, known as first-generation or typical antipsychotics, e.g. haloperidol and chlorpromazine, block the activity of dopamine 2D2 receptors in the brain and reduce symptoms such as hallucinations and delusions. Symptom reduction suggested that dopamine plays a significant role in psychosis. Amphetamines and cocaine can induce psychosis in people without schizophrenia and can also bring on the disorder. Almost any drug of abuse, particularly marijuana, can increase the risk of schizophrenia in biologically vulnerable individuals. However, because medications that reduce dopamine activity do not alleviate all the symptoms of schizophrenia, it seems likely that other neurotransmitters or other factors are involved as well. Other neurochemical hypotheses. Second-generation atypical antipsychotics block serotonin, 5-hydroxytryptamine 2A or 5-HT2A, and dopamine, which suggests that serotonin may play a role in schizophrenia as well. Phencyclidine, PCP, induces a state that resembles schizophrenia. This observation led to interest in the N-methyl-D aspartate, NMDA receptor complex, and the possible role of glutamate in the pathophysiology of schizophrenia. Glutamate, dopamine, and serotonin act synergistically in neurotransmission, and thus glutamate may also play a role in causing psychosis. Neurotransmission by another calming neurotransmitter, gamma-aminobutyric acid, or GABA, is also impaired in schizophrenia. Acetylcholine, active in the muscarinic system, may play a role in psychosis. Brain structure abnormalities. It is possible that structural abnormalities cause disruption in communication within the brain. Structural differences may be due to errors in neurodevelopment or errors in the normal pruning of neuronal tissue that happens in late adolescence and early adulthood. Inflammation or neurotoxic effects from factors such as oxidative stress, infection, or autoimmune dysfunction may also alter the brain structure. Using brain imaging techniques, computed tomography, CT, magnetic resonance imaging, MRI, functional MRI, fMRI, and positron emission tomography, PET, researchers demonstrated structural brain abnormalities including reduced volume in the right anterior insula may contribute to negative symptoms, reduced volume and changes in the shape of the hippocampus, accelerated age-related decline in cortical thickness, gray matter deficits in the dorsolateral prefrontal cortex area, thalamus, and anterior cingulate cortex, as well as in the frontotemporal, thalamocortical, and subcortical limbic circuits. Reduced connectivity among various brain regions, neuronal overgrowth in some areas, possibly due to inflammation or inadequate neural pruning, widespread white matter abnormalities, e.g. in the corpus callosum. PET scans also show a lowered rate of blood flow and glucose metabolism in the prefrontal cortex. This executive functioning part of the brain governs planning, abstract thinking, social adjustment, and decision-making. Figure 3.5 in Chapter 3 shows a PET scan demonstrating reduced brain activity in the frontal lobe of a patient with schizophrenia. Such structural and functional changes may worsen as the disorder continues. Postmortem studies show a reduced volume of gray matter, especially in the temporal and frontal lobes. People with the most tissue loss had the worst symptoms. Psychological and environmental factors. A number of biological, chemical, and environmental stressors are believed to combine with genetic vulnerabilities to produce schizophrenia. A lot of pictures in a table here on page 195. You should look at that later. Prenatal stressors. Infection during pregnancy increases the risk of mental illness in the child. Prenatal infections in the mother also increase the risk of infection in the child after birth, and those infections in the children also can make them more vulnerable to mental illness. Other factors associated with an increased risk of schizophrenia include a father older than 35 at the child's conception, and a child being born during late winter or early spring. Psychological stressors. Stress increases cortisol levels, impeding hypothalamic development and causing other changes that may precipitate the illness in vulnerable individuals. Schizophrenia often manifests at times of developmental and family stress, such as beginning college or moving away from one's family. Social, psychological, and physical stressors may play a significant role in both the severity and course of the disorder and the person's quality of life. Other risk factors include childhood sexual abuse, exposure to social adversity, e.g. chronic poverty, migration to or growing up in a foreign culture, and exposure to psychological trauma or social defeat. These factors may cause structural changes in the brain via epigenetic changes to the genome. Even psychological trauma in a parent or grandparent may cause epigenetic changes that increase vulnerability, and this increased risk can be passed on to one's descendants. Environmental stressors. Environmental factors, such as toxins, including the solvent tetrachloroethylene used in dry cleaning to line water pipes, and sometimes found in drinking water, are also believed to contribute to the development of schizophrenia in vulnerable people. Living in urban areas or high-crime environments is also believed to increase the risk of schizophrenia. Prognostic considerations. For most individuals, symptoms improve with medications and psychosocial interventions. As a result, many people with schizophrenia experience a good quality of life and success within their families, occupations, and other roles. In many cases, schizophrenia does not respond fully to treatments, leaving mild to severe residual symptoms and varying degrees of dysfunction or disability. A minority of individuals requires repeated or lengthy inpatient care or institutionalization. Factors associated with a less positive prognosis include a slow onset, e.g. more than 2 to 3 years, younger age at onset, longer duration between first symptoms and first treatment, longer periods of untreated illness, and more negative symptoms. Reducing the frequency, intensity, and duration of relapse when previously controlled symptoms return is believed to improve the long-term prognosis. Phases of schizophrenia. Schizophrenia usually progresses through predictable phases, although the presenting symptoms during a given phase and the length of the phase can vary widely. These phases are prodromal, mild changes in thinking, reality testing, and mood, insufficient to meet the diagnostic criteria for schizophrenia. Symptoms appear a month to more than a year before the first full-blown episode of the illness. During this phase, speech and thought may be odd or eccentric. Anxiety, obsessive thoughts, and compulsive behaviors may be present. Deterioration in concentration, school or job performance, and social functioning are accompanied by distressing thoughts, suspiciousness, memory impairment, and significant disorganization in speech or behavior. The person may feel that he or she is not right or that something strange is happening. Acute. Later symptoms vary from few and mild to many and disabling. Symptoms such as hallucinations, delusions, apathy, social withdrawal, diminished affect, anhedonia, disorganized behavior, impaired judgment, and cognitive regression result in functional impairment. As symptoms worsen, the person has difficulty coping, and symptoms once concealed become apparent to others. Increased support or hospitalization may be required. Stabilization. Symptoms are stabilizing and diminishing, and there is movement towards a previous level of functioning, baseline. Care in an outpatient mental health center or partial hospitalization program, which includes many of the services offered in inpatient mental health units, but without an overnight stay in the hospital, may be needed. The person may receive care in a residential crisis center, similar to a mental health unit but based in the community and less restrictive in nature, or a staff-supervised residential group home or apartment. Maintenance or residual. The condition has stabilized and a new baseline is established. Positive symptoms, which will be described later, are usually absent or significantly diminished, but negative and cognitive symptoms continue to be a concern. Ideally, recovery with few or no residual symptoms will occur, and the patient is again able to live independently or with family. A pattern of recurrent exacerbations, worsening of symptoms, separated by periods of reduced or dormant symptoms, is common. Some people have several episodes and none thereafter. For most patients, however, schizophrenia is a chronic disorder that, like diabetes or heart disease, is managed with ongoing treatment. Applications of the nursing process. Assessment. Assessment involves interviewing the patient and observing behavior and other manifestations of the disorder. Information from others who know the patient is also important, as patients may conceal or minimize symptoms. Assessment should include a mental status examination along with a review of spiritual, cultural, biological, psychological, social, and environmental elements that might be affecting the presentation. Trust, a therapeutic nurse-patient relationship, sound therapeutic communication skills, and an understanding of the disorder and what patients may be experiencing all strengthen the assessment. Prodromal phase. Early assessment plays a key role in improving the prognosis for individuals with schizophrenia. Intervening at this early stage to reduce risk factors, such as high levels of stress and substance abuse, coupled with enhancing social and coping skills, can reduce the risk of developing schizophrenia in biologically vulnerable people. Box 12.1 identifies other schizophrenia prevention strategies during this phase. Box 12.1, can schizophrenia be prevented? Malnutrition, infection, and tobacco use during pregnancy, and marijuana and drug use in biologically vulnerable people increase the risk of developing schizophrenia. Primary prevention aims at avoiding these factors. However, not all risk factors can be avoided. Avoiding triggers, such as environmental stressors, and interventions to promote resiliency and coping in children and families are helpful. Two additional options are 1. Early treatment with antipsychotic medications, and 2. Supplemental essential fatty acids. Assessment tools help to identify prodromal early symptoms such as eccentric or magical thinking, cognitive disorganization, or quasi-hallucinations. Once at-risk symptoms are identified, antipsychotic medications may reduce the development or severity of schizophrenia. Controversially, only 1/3 of those deemed at risk for schizophrenia actually develop the disorder. Prophylactic antipsychotic use can unnecessarily expose people to significant side effect risks. More promising is the use of omega-3 and omega-6 polyunsaturated fatty acids found in fish oils and oily fish such as tuna, salmon, and sardines. These fats are abnormally low in the brains of people with schizophrenia. They reduce inflammation and free radicals in the brain and contribute to ACH and serotonin stability. Preliminary evidence suggests that fatty acid supplements reduce rates of conversion from at risk to actually having schizophrenia from 27 to 5%. General assessment. Not all people with schizophrenia have the same symptoms, and some of the symptoms of schizophrenia are also found in other disorders. Figure 12.1 describes the four main symptom categories in schizophrenia. 1. Positive symptoms. The presence of something that should not be present. Positive symptoms include hallucinations, delusions, paranoia, or disorganized or bizarre thoughts, behavior, or speech. 2. Negative symptoms. The absence of something that should be present. Negative symptoms include the inability to enjoy activities, social discomfort, or lack of goal-directed behavior. 3. Cognitive symptoms. Subtle or obvious impairment in memory, attention, thinking, e.g. disorganized or irrational thoughts, judgment, or problem-solving. 4. Affective symptoms. Symptoms involving emotions and their expression. Positive symptoms. The positive symptoms usually appear early. Their dramatic nature captures our attention and is often what precipitates treatment. These symptoms are what most individuals associate with mental illness, making schizophrenia the classic crazy disorder. Positive symptoms include alterations in reality testing. We all experience thoughts that are irrational or distorted, yet we can usually catch and correct the error by using reality testing. Reality testing is the automatic and unconscious process by which we determine what is and is not real. You might think you hear a voice, but you see that no one is present. You conclude you are mistaken. It wasn't real. With impaired reality testing, the person believes that hallucinations or delusions are real. Delusions are false beliefs held despite a lack of evidence to support them. The most common delusions involve persecutory, grandiose, or religious ideas. Table 12.1 provides definitions and examples of types of delusions. Delusions can reflect underlying issues or needs, e.g. a person with poor self-esteem may believe he is Beethoven or God, possibly driven by a need to feel more beloved or powerful. Just because someone has a mental illness does not mean that every story that sounds improbable is delusional. One patient repeatedly told the staff that the mafia was out to kill him. The staff later learned that he had been selling drugs and had not paid his drug sources, and that drug dealers were trying to harm him. Alterations in speech. A striking positive symptom of schizophrenia spectrum disorders is the use of unusual speech patterns. One of the most common, associative looseness, or looseness of association, results from haphazard and illogical thinking, where concentration is poor and individuals loosely associate their thoughts. For example, I need to get a Band-Aid. My friend was talking about AIDS. Friends talk about French fries, but how can you trust the French? A word salad. The most extreme form of associative looseness is a jumble of words that is meaningless to the listener, e.g., throat hoarse strength of policy highlighters on a boat reigning supreme. Clang association is choosing words based on their sound rather than their meaning, and often involves words that rhyme or have a similar beginning sound. On the track, have a Big Mac, or click clack clutch close. Neologisms are words that have meaning for the patient but a different or non-existent meaning to others. A person may use a known word differently than others understand it, or can create a completely new word that others do not understand, e.g., his mannerologies are poor. Echolalia is the pathological repeating of another's words, occurring perhaps because the patient's thought processes are so impaired that he is unable to generate speech on his own. Nurse: Mary, come get your medication. Mary: come get your medication. Other pathological speech patterns are circumstantiality, including unnecessary and often tedious details in conversation, but eventually reaching the point. Tangentiality, wandering off topic or going off on tangents and never reaching the point. Cognitive retardation, generalized slowing of thinking, which is represented by delays in responding to questions or difficulty finishing thoughts. Pressured speech, urgent or intense speech, resists allowing comments from others. Flight of ideas, moving rapidly from one thought to the next, often making it difficult for others to follow the conversation. Symbolic speech, using symbols instead of direct communication. For example, a patient reports, demons are sticking needles in me, when what he means is that he is experiencing a sharp pain, symbolized by needles. Thought blocking, a reduction or stoppage of thought, interruption of thought by hallucinations can cause this. Thought insertion, the uncomfortable belief that someone else has inserted thoughts into your brain. Thought deletion, a belief that thoughts have been taken or are missing. Other positive symptoms manifested in disorders of thought include magical thinking, believing that thoughts or actions affect others. This is common and usually non-pathological in children, e.g., wearing pajamas inside out to make it snow, or because I was mad at him, he fell down. Paranoia, an irrational fear ranging from mild, wary, guarded, to profound, believing irrationally that another person intends to kill you. Fear may result in defensive actions, harming another person before that person can harm the patient. Alterations in perception. Alterations in perception involve errors in how one interprets perceptions or perceives reality. The most common perceptual errors are hallucinations. Hallucinations occur when a person perceives a sensory experience for which no external stimulus exists, e.g., hearing a voice when no one is speaking. Types of hallucination include auditory, hearing voices or sounds, visual, seeing people or things, olfactory, smelling odors, gustatory, experiencing tastes, tactile, feeling bodily sensations, e.g., feeling an insect crawling on one's skin. Auditory hallucinations, the most common form in schizophrenia, are experienced by more than 60% of people with schizophrenia. They may be vague sounds or indistinct or clear voices. Hallucinations seem to come from outside the person's head. Auditory processing areas of the brain are activated during these hallucinations, just as they are when a genuine sound is heard. John Nash, the world-renowned mathematician with schizophrenia portrayed in the film A Beautiful Mind, 2001, describes his hallucinations. I thought of the voices as something a little different from aliens. I thought of them more like angels. It's really my subconscious talking. It was really that. I know that now. Internal voices may be single or multiple, distinct or indistinct, and can be attributed to specific sources, e.g. God, a family member, or unrecognized. They may be supportive and pleasant, or derogatory and frightening. They can be subtle and unobtrusive, or intrusive and highly distressing. Hallucinations commenting on the person's behavior or conversing with the person are common. Indications that a person is hallucinating include tracking motions, turning one's head in the direction of the perceived sound, lips moving silently, talking as if to another when no one is present, and otherwise unexplained changes in affect, e.g., suddenly laughing without apparent reason. A person who hears voices struggles to understand the experience, sometimes developing related delusions to explain the voices, e.g., believing the voices are from God or due to a device implanted by the CIA. Patients may attempt to cope by drowning out auditory hallucinations with loud music or by competing with them by talking loudly, humming, or singing. Such auditory competition, in fact, may reduce hallucinations and serve as a recommended intervention. A command hallucination is a particularly disturbing symptom that directs the person to take an action. This type of hallucination must be monitored carefully because they may be dangerous. For example, telling a patient to jump out of the window or hit that nurse. Command hallucinations are often frightening and may be a warning flag for a psychiatric emergency. It is essential to assess what the patient hears, the ability to recognize a hallucination as not real, and the patient's ability to resist any commands. Visual hallucinations are the second most common form in schizophrenia. They may involve distortion of visual stimuli or can be formed and realistic images. Seeing individuals and animals are most common. Olfactory, tactile, or gustatory hallucinations are unusual in mental illness. When present, other causes should be investigated. Other alterations in perception are illusions, misperceptions or misinterpretations of a real experience. For example, a man sees a coat on a shadowy coat rack and believes it is a bear. Depersonalization, a feeling of being unreal or having lost identity. Body parts do not belong or the body has drastically changed, e.g., a patient may see the fingers as being smaller or not theirs. Derealization, a feeling that the environment has changed, e.g., everything seems bigger or smaller or familiar surroundings seem somehow strange and unfamiliar. Alterations in behavior. Alterations in behavior involve changes in the speed of movement and behaviors that are illogical or inappropriate, including catatonia, a pronounced increase or decrease in the rate and amount of movement. Excessive motor activity is purposeless and accompanied by echolalia, repeating others' words, and echopraxia, mimicking others' movements. The most common form of catatonia is when the person moves little or not at all. Muscular rigidity, or catalepsy, may be so severe that the limbs remain in whatever position they are placed. Freezing in place may result in problems such as exhaustion, pneumonia, blood clotting, malnutrition, or dehydration. Waxy flexibility, maintaining a given posture inappropriately, usually seen in catatonia. For example, when the nurse raises the arm, the patient continues to hold his position in a statue-like manner. Motor retardation, a pronounced slowing of movement. Motor agitation, excited behavior such as running or pacing rapidly, often in response to internal or external stimuli. The agitation can put the patient at risk, e.g., exhaustion, or running into traffic, or others at risk, being knocked down. Stereotyped behaviors, repetitive behaviors that do not serve a logical purpose. Echopraxia, the mimicking of movements of another. Negativism, a tendency to resist or oppose the requests or wishes of others. Impaired impulse control, a reduced ability to resist one's impulses. Examples include interrupting in the group setting or throwing unwanted food on the floor. It can increase the risk of assault. Gesturing or posturing, assuming unusual and illogical expressions, often grimaces or positions. Boundary impairment, an impaired ability to sense where one's body or influence ends and another begins. For example, a patient might stand too close to others or might drink another's beverage, believing that because it is near, it is theirs. Negative symptoms. Positive symptoms are so attention-getting, they make treatment seem more urgent than negative symptoms. Yet negative symptoms are serious problems for people with schizophrenia because they are the absence of essential human qualities. Treating negative symptoms is more difficult than treating positive symptoms. Negative symptoms include the following 6 symptoms that all start with the letter A. Anhedonia, an, without, hedonia, pleasure, a reduced ability or inability to experience pleasure in everyday life. Avolition, A, without, volition, making a decision. Loss of motivation, difficulty beginning and sustaining goal-directed activities, reduction in motivation or goal-directed behavior. Asociality, decreased desire for or comfort during social interaction. Affective blunting, reduced or constricted affect. Apathy, a decreased interest in or attention to activities or beliefs that would otherwise be interesting or important. Alogia, reduction in speech, sometimes called poverty of speech. These symptoms can contribute to poor social functioning and social withdrawal. They can impede a person's ability to initiate and maintain conversations and relationships or succeed in school or work. Apathy and avolition result in deficits in basic activities, such as maintaining adequate hygiene, grooming, and other activities of daily living. Affect, an additional A word, is the external expression of a person's internal emotional state. In schizophrenia, affect may be diminished or not coincide with inner emotions. Some antipsychotics can also cause diminished affect. Affect in schizophrenia can usually be categorized in one of four ways: flat, immobile, or blank facial expression; blunted, reduced or minimal emotional response; constricted, reduced in range or intensity, e.g., shows sadness or anger, but no other moods; inappropriate, incongruent with the actual emotional state or situation, e.g., laughing in response to a tragedy; bizarre, odd, illogical, inappropriate, or unfounded, includes grimacing. Cognitive symptoms. Cognitive symptoms represent the third symptom group and are evident in most patients with schizophrenia. These impairments can lead to poor judgment and leave the patient less able to cope, learn, manage health, or succeed in school or work. Cognitive symptoms include the following. Concrete thinking is an impaired ability to think abstractly, resulting in interpreting or perceiving things in a literal manner. For example, a nurse might ask what brought the patient to the hospital, and the patient answers, a cab, rather than explaining a suicide attempt. Interpreting proverbs can be used to assess abstract thought. An abstract interpretation of the grass is always greener on the other side of the fence is that it always seems we would be happier given other circumstances. A concrete interpretation could be that side gets more sun, so it's greener there. Concreteness reduces one's ability to understand and respond to concepts requiring abstract reasoning, such as love or humor. Concreteness, especially when combined with an impaired ability to recognize variations in affect or tone of voice, can also make it difficult to recognize social cues such as sarcasm. For example, a patient who had forgotten his wallet asked a store clerk if he could pay later for a bag of chips. When the clerk sarcastically replied, "Oh, sure, we let our customers pay whenever they want," the patient took this literally. The patient was distressed when police arrested him for theft despite his protests that he had permission not to pay. Impaired memory impacts short-term memory and the ability to learn. Repetition and verbal or visual cues may help the patient to learn and recall needed information. E.g., a picture of a toothbrush on the patient's wall as a reminder to brush his or her teeth. Impaired information processing can lead to problems such as delayed responses, misperceptions, or difficulty understanding others. Patients may lose the ability to screen out insignificant stimuli, such as background sounds or objects in one's peripheral vision. This can lead to overstimulation. Impaired executive functioning includes difficulty with reasoning, setting priorities, comparing options, placing things in logical order or groups, anticipation and planning, and inhibiting undesirable impulses or actions. Impaired executive functioning interferes with problem solving and can contribute to inappropriateness in social situations. Affective symptoms. Affective symptoms are those that involve the experience and expression of emotions. They are common and increase patient suffering. Mood may be unstable, erratic, labile, changing rapidly and easily, or incongruent, not what would be expected for the circumstances. A serious affective change often seen in schizophrenia is depression. Depression may occur as part of a shared inflammatory reaction affecting the brain, or may simply be a reaction to the stress and despair that can come from living with a chronic illness. Assessment for depression is crucial because it may indicate an impending relapse, further impair functioning, and increased risk of substance use disorders. Most importantly, depression puts people at increased suicide risk. Self-assessment. People with schizophrenia often experience anosognosia, an inability to realize they are ill, caused by the illness itself. Anosognosia may result in the patient resisting or stopping treatment. making care challenging and frustrating to staff. The inability to recognize the illness, along with paranoia, creates a situation in which requesting or even accepting help is impossible. Working with individuals who have schizophrenia can bring about anxiety or fear. Discussing your feelings with staff, faculty, and peers may help. Examining whether one's expectations of patients are realistic, learning more about the nature of the illness, and seeking new, more effective ways of helping patients can help staff overcome feelings of helplessness and reduce countertransference. There's a couple of boxes here. We can look at those later. Diagnosis. Patients with schizophrenia have multiple distressing and often disabling symptoms. They require a multifaceted approach to care and treatment of both the patient and the family. Table 12.2 lists signs and symptoms and potential nursing diagnoses for persons with schizophrenia. Outcomes identification. Nursing Outcomes Classification, NOC, is one useful guide for developing outcomes. Outcomes should focus on illness knowledge, management, coping, and quality of life. Outcomes should be consistent with the recovery model, referred to Chapter 32, which stresses hope, living a full and productive life, and eventually recovery, rather than focusing on controlling symptoms and adapting to disability. Desired outcomes vary with the phase of the illness. Phase 1, acute. For the acute phase of schizophrenia, the overall goal is patient safety and stabilization. If the patient is a risk to self or others, initial outcomes criteria address such safety issues, e.g., patient refrains from self-injury, hyponatremia is prevented. Another example of a desired outcome is a patient who consistently labels hallucinations as not real, a symptom of an illness. Phase 2, stabilization. Outcome criteria during Phase 2 focus on a patient understanding of the illness and treatment, achieving an optimal medication and psychosocial treatment regimen, and controlling and/or coping with symptoms and side effects. The outcomes target the negative and cognitive symptoms, as these tend to respond less well to initial treatment than do positive symptoms and may reduce treatment success. Phase 3, maintenance. Outcome criteria for Phase 3 focus on maintaining and increasing symptom control and insight. Measures during the maintenance phase include adhering to treatment, preventing relapse, maintaining and increasing independence, and achieving a satisfactory quality of life. Planning. Again, the planning of appropriate interventions is guided by the phase of the illness and the strengths and needs of the patient. Cultural considerations, available resources, and patient preferences influence planning. Phase 1, acute. Hospitalization is indicated if the patient is considered a danger to self or others, e.g., refuses to eat or is too disorganized to function safely in the community. It may also be needed to clarify and confirm the diagnosis. Planning focuses on selecting the best strategies to ensure patient safety and control symptoms. Phase 2, stabilization, and Phase 3, maintenance. Planning during the stabilization and maintenance phases focuses on providing patient and family education, support, and skills training. Planning incorporates interpersonal, functional, coping, healthcare, shelter, educational, and vocational strengths and needs, and addresses how and where these needs can best be met within the community. Relapse prevention efforts, box 12.2, are vital. Each relapse of psychosis may increase residual dysfunction and deterioration and can contribute to despair, hopelessness, and suicide risk. Recognition of the early warning signs of relapse, such as reduced sleep, social withdrawal, and worsening concentration, followed by close monitoring and intensification of treatment, is essential to minimize the duration of psychotic episodes and resulting disruption to the patient's life. Implementation. Phase 1, acute. Settings. In general, during the acute phase of schizophrenia, 24-hour support is required to prevent harm to self or others. Hospitalization provides external structure and support, e.g., others guiding the patient's activities. As previously discussed, anosognosia is a symptom of schizophrenia that may impair a person's ability to recognize that he or she is ill. In this case, court-ordered hospitalization might be required. While a minority of patients require extended inpatient care, more than 1 month, the length of hospitalization or other intensive treatment during the acute phase is typically short, days to weeks, ending when acute symptoms have been stabilized. However, this does not necessarily take into account the extended time needed for full recovery from serious mental illness, making continued engagement and care in the community all the more important after discharge. Community-based services provide such care during the stabilization and maintenance phases. Interventions. Structure within the therapeutic milieu provides a feeling of safety and security for patients who have been experiencing severe anxiety. Patients are monitored for suicide risk and intervene promptly to address risk factors such as despair or hopelessness and provide for the patient's safety. Virtually all people with psychotic disorders will be given pharmacological treatments to manage positive and negative symptoms. Medication response is monitored and side effects will be addressed. For example, fluid intake and weight can be assessed to identify polydipsia. Registered nurses provide support, psychoeducation, and guidance regarding the nature of the illness and its treatment. Psychoeducation promotes patient-centered care by helping the patient to recognize and self-manage symptoms such as anxiety, impaired concentration, social withdrawal, impaired rest or nutrition, impaired cognition, and hallucinations and delusions. Working with an aggressive patient. A small percentage of patients with schizophrenia, especially during the acute phase, may exhibit a risk for physical violence. Violence may be in response to hallucinations, especially command hallucinations, delusions, paranoia, and impaired judgment or impulse control. Interpersonal conflict, fear, desperation, and conflicts, e.g., about unit rules, also increase the risk of aggression. Assessment and periodic reassessment for risk of violence are essential. When the potential for violence exists, measures to protect the patient and others become a priority. Refer to Table 12.3 and Chapter 27 for more information on caring for the aggressively or potentially violent patient. Phase 2. Stabilization, and Phase 3. Maintenance. Effective long-term care of patients with schizophrenia relies on a four-pronged approach. 1. Medication. 2. Treatment adherence. 3. Relationships with trusted care providers and support people. 4. Community-based therapeutic services. All care is geared towards the patient's strengths, cultures, personal preferences, and needs. Communication, continuity in care, and trusting relationships with care providers are essential for optimum recovery and relapse prevention. Post-discharge care typically includes group and individual psychotherapy and psychoeducation, e.g., social or coping skills. Medication and case management and structured activities such as day programs and recreational activities. Community mental health centers usually provide medication services, day treatment, case management, and 24/7 crisis and psychiatric emergency services. Community mental health care can also provide housing support, allied physical health services, employment programs. Peer-led services are available in most communities. These services include drop-in centers, sometimes called clubhouses, that offer socialization, activities, and sometimes employment opportunities. Hospital staff must be aware of such community services and ideally should directly connect patients and families with these resources before discharge. Support groups are also very helpful and patients and family members should be connected to these, e.g. the National Alliance on Mental Illness, NAMI. Nurses provide essential family psychoeducation about the illness and how best to help the patient. Education can be provided even if the patient does not provide consent, if the family initiates the request and the information is provided in a way that does not divulge confidential health information about the patient. Alternately, The family can be connected to other resources for information. NAMI's family-to-family program educates families about severe mental health illness and their treatment. Support and respite for caregivers are also important. A sample care plan can be found in the case study and nursing care plan box. Additional nursing interventions, often helpful in caring for individuals with schizophrenia, are provided in Table 12.3. A lot of tables, case study here for the next 2 pages. Ooh. Oh, and there's more. 2 more pages of tables. We can look at those later. Teamwork and safety. A therapeutic milieu provides structure, a planned, consistent routine, and external limits that create a sense of security. It is a physical and social environment that maximizes safety, opportunities for learning and practicing skills, such as conflict resolution, stress reduction, and symptom management techniques. And therapeutic activities, e.g., games that promote socialization, therapy groups that help develop insight or coping abilities, while minimizing undue stress and stimulation. Hospital alternatives, e.g., crisis centers, partial hospital programs, also provide a therapeutic milieu in a less restrictive setting. Activities in groups. Participation in activities in groups appropriate to the patient's needs and abilities may decrease withdrawal, enhance motivation, modify unacceptable behaviors, improve understanding of the illness, facilitate support and feedback with staff and peers, and increase social competence and other skills. Drawing, poetry, journaling, and listening to music promote the recognition and expression of feelings. Self-esteem is enhanced by a task completion and participation in activities for which there is a high likelihood of success. Recreational activities such as picnics and outings to stores or restaurants are not simply diversions. They teach and provide practice opportunities that improve constructive leisure skills, the ability to make meaningful and rewarding use of free time, increase social comfort, build interactional skills, promote interdependence, and improve boundaries. Outpatient programs can provide structure after discharge. Counseling and communication techniques. Therapeutic communication techniques for patients with schizophrenia aim to build trust and reduce anxiety. Staff should remember that patients with schizophrenia may have memory and attentional impairment and require repetition in visual and verbal reminders to promote learning and task completion. People who think concretely also benefit from concrete examples during education, e.g., counting out the equivalent number of sugar cubes found in a bottle of cola to show its sugar content. Shorter, less than 30 minutes, but more frequent interactions may be less stimulating and better tolerated than fewer, longer interactions. Intervening with hallucinations. When a patient is hallucinating, the nurse focuses on understanding the patient's experiences and responses. Suicidal or homicidal themes or commands necessitate appropriate safety measures. For example, if internal voices tell a patient that a peer plans to do harm, it may lead the patient to act aggressively against that person. In that case, close monitoring, helping the patient feel safe, and maintaining separation of the patient and potential victim would be indicated. Hallucinations are real to the person who is experiencing them and may be distracting during interactions. They can be supportive or terrifying, faint or loud, episodic or constant. They can be sounds or voices, and are sometimes attributed to specific sources, e.g. a parent or God. Nursing care includes calling the patient by name, speaking simply and loudly enough to be understood during auditory hallucinations, presenting in a supportive manner, maintaining eye contact, and redirecting the patient's focus to your conversation as needed. See box 12.3 regarding helping patients experiencing hallucinations. That box is on the next page along with another one. Takes up the whole page. We can look at that later. Intervening with delusions. Impaired reality testing prevents self-correction of irrational thoughts that normally would be disregarded. When the nurse attempts to see the world through the patient's eyes, it becomes easier to understand the patient's delusion. For example, patient, you people are all alike, all part of the FBI plot to destroy me. Nurse, it seems to you like people want to hurt you. That must be very frightening. I will not hurt you, and we can work together to help you feel safer. Here the nurse acknowledges the patient's experience and the feelings, conveys empathy about the patient's fearfulness, provides reassurance about her intentions, avoids questioning the delusion itself, and focuses on helping the patient feel safer, addressing the underlying theme of fear. Focus on the delusion itself, the beliefs about the FBI, is not helpful. Focusing on fear, its causes, and what can help the patient feel more secure is therapeutic. Until reality testing improves, it is never useful to try to prove that the delusion is incorrect. This can instead intensify the delusion and cause the patient to view staff as individuals who cannot be trusted. However, it is helpful to clarify misinterpretations of the environment and gently suggest, as tolerated, a more reality-based perspective. For example, patient, I see the doctor's here, he wants to kill me. Nurse, it is true the doctor wants to see you, as he talks with all patients about their treatment. Would you feel more comfortable if I stayed with you during your meeting? Focusing on activities and events occurring in the present keeps the focus on reality and provides opportunities to distinguish what is real. Work with the patient to find and promote helping coping strategies. Box 12.4 provides strategies for working with patients experiencing delusions. Intervening with associative looseness. Associative looseness is a reflection of idiosyncratic and disorganized thinking. Increased anxiety or overstimulation worsens cognitive disorganization. Guidelines for helping those with disorganized thinking include: do not pretend or allow the patient to think that you understand when you don't. Place the difficulty in understanding on yourself, not on the patient. Example, I'm having trouble following what you're saying, not, you're not making any sense. Tell the patient what you do understand and reinforce clear communication of needs, feelings, and thoughts when it occurs. Look for recurring issues and themes in the patient's communications and tie these to possible triggers. Example, you mentioned trouble with your brother several times, usually after your family has visited. Tell me about your brother and your visits with him. Summarize or paraphrase the patient's communications to role model clear communication and to give the patient a chance to correct anything you may have misunderstood. Speak concisely, clearly, and concretely in sentences rather than paragraphs. Health teaching and health promotion. Ideally, patients and family members or caregivers are included in teaching. Often, home lives have been stressed by the illness. Significant others may have become critical, controlling, or intrusive. Lack of understanding of the disease and its symptoms can lead others to mistake symptoms such as apathy and poor hygiene as intentionally bad behavior. A warm, concern, and supportive environment free of conflict and chaos promotes recovery. Teaching significant others how to recognize and respond healthfully to symptoms and how to negotiate to achieve needed changes is very important. Education should include the causes and nature of the illness, what to expect, how it is treated, ways to cope and control the illness, medications and side effects, helpful resources, and relapse prevention. This knowledge and skill helps the patient and family to become actively involved in managing symptoms and the illness. Including family members reduces family anxiety and distress and helps them reinforce the patient's and staff's efforts. Box 12.5 identifies patient and family teaching about schizophrenia. Additional nursing interventions for patients with schizophrenia are listed in Table 12.3. Psychobiological interventions. Antipsychotic medications, those used to treat psychotic disorders such as schizophrenia, first became available in the 1950s. Previously available medications provided sedation, but did not reduce psychosis. Until the late 1960s, Patients with schizophrenia usually spent months or years in state or private hospitals, resulting in great emotional and financial costs to patients, families, and society. Antipsychotic drugs at last provided symptom control and allowed most patients to live and be treated in the community. Drugs used to treat psychotic disorders include 1. First-generation antipsychotics, FGAs, traditional dopamine D2 receptor antagonists, also known as typical antipsychotics or neuroleptics, e.g. haloperidol or Haldol. 2. Second-generation antipsychotics, SGAs, serotonin 5-HT2A receptor and dopamine D2 receptor antagonists, e.g. clozapine, clozaril. Other drugs are antagonists in areas of high dopamine activity, but agonists in areas of low dopamine activity, e.g. aripiprazole or Abilify. The FGAs primarily affect positive symptoms, e.g. hallucinations and delusions, but have little effect on negative symptoms. Second-generation antipsychotics treat positive symptoms and can also help negative symptoms, e.g. asociality, blunted affect, though improvement in negative and cognitive symptoms is usually less. Second-generation drugs are generally an improvement on earlier drugs while reducing the overall burden of side effects. All antipsychotic agents usually take 2 to 6 weeks to achieve the desired effects. Patient-specific dosage adjustment is required to obtain an optimal balance between effectiveness and side effects. Treatment guidelines recommend monotherapy or the use of a single medication. After the failure of 2 monotherapy trials, a clozapine, clozaril, monotherapy trial is warranted. Polypharmacy is avoided if at all possible. However, if clozapine results in failure or intolerance, an adjunctive antipsychotic may be used to improve the response of another. Antipsychotics are not addictive. However, they should be discontinued gradually to minimize a discontinuation syndrome that can include dizziness, nausea, tremors, insomnia, electric shock-like pains, and anxiety. Antipsychotics are unlikely to be lethal in overdose situations. A lesser-known risk of all antipsychotic medications due to dopamine blockade or sedation is impaired swallowing. This may cause drooling and risk of choking. Also, patients taking antipsychotics are at increased fall risk due to orthostatic, postural, hypotension, sedation, and gait impairment. Liquid or fast-dissolving forms available for selected antipsychotics can make it difficult for a person to cheek or palm his medicine, hide it in his cheek or palm, and later dispose of it. See Table 12.3 for interventions to prevent cheeking and palming. Injectable antipsychotics. Some antipsychotics are available in short-acting injectable form, used primarily for treatment of agitation, behavioral emergencies such as assaultiveness, or when a patient refuses court-mandated oral antipsychotics. Side effects can be intensified and less easily managed when medication is administered directly into the system intramuscularly, IM. Some are available in long-acting injectable LAI formulations that only need to be administered every 2 to 4 weeks and in one case every 3 months. Some require special administration protocols, Table 12.4. By requiring less frequent medication administration, adherence is improved and conflict about taking medications is reduced. The downside is lack of dosing flexibility, and patients may feel like they have less control and are coerced. Additional information on antipsychotic medications can be found in Table 12.5. First-generation antipsychotics. FGAs are used less in schizophrenia because of their minimal impact on negative symptoms and their generally higher levels of side effects. However, they are as effective against positive symptoms as newer antipsychotics and are much less expensive than some SGAs. For patients untroubled by their side effects, FGAs remain an appropriate choice. especially when cost or metabolic syndrome, more common in SGA drugs and described later in this chapter, is a concern. First-generation antipsychotics are dopamine D2 antagonists in both limbic and motor centers. Blockage of D2 receptors in motor areas causes extrapyramidal side effects, EPS, including 1. Acute dystonia, sudden sustained contraction of one or several muscle groups, usually of the head and neck. Acute dystonias can be frightening and painful, but unless they involve muscles affecting the airway, which is rare, they are not dangerous. However, they cause significant anxiety and should be treated promptly. 2. Akathisia, a motor restlessness that causes pacing, repetitive movements, or an inability to stay still or remain in one place. It can be severe and distressing to patients. It can be mistaken for anxiety or agitation. Sometimes, more of the drug that caused the akathisia is mistakenly given, which makes the side effect worse. A tardive form can persist despite treatment. 3. Pseudo-Parkinsonism, a temporary group of symptoms that looks like Parkinson's disease, tremor, reduced accessory movements, e.g. arms swinging when walking, gait impairment, reduced facial expressions, mask facies, and slowing of motor behavior, bradykinesia. Definition provided here of masked facies from verywellhealth.com. Masked facies, also known as hypomimia, is the loss of facial expressions most commonly associated with Parkinson's disease. It is so named because the condition gives the affected person a fixed, mask-like expression. Lowering dosages can minimize EPS, and EPS can be treated or prevented by using antipsychotics less prone to causing EPS. These unusual side effects may diminish with time. Oral anti-Parkinsonian drugs are also useful. However, these drugs have their own side effects because most are anticholinergic. Abuse of anti-Parkinsonian drugs is also a problem because they can cause an enjoyable altered sensorium. Trihexyphenidyl artane is the most common drug in this category, but other anticholinergics, drugs such as benztropine cogentin, are also used to get high. Tardive dyskinesia is a persistent EPS side effect involving involuntary rhythmic movements. Tardive dyskinesia develops in 10% or more of patients, usually after prolonged treatment, and often persists even after the medication has been discontinued. This side effect usually begins in oral and facial muscles and progresses to include the fingers, toes, neck, trunk, or pelvis. More common in women, tardive dyskinesia varies from mild to severe and can be disfiguring or incapacitating. The National Institute of Mental Health developed the Abnormal Inventory Movement Scale, AIMS, to identify and track involuntary movements. Using the AIMS is a key nursing role in treating this population. The FDA recently approved valbenazine capsules, Ingrezza, for the treatment of tardive dyskinesia in adults. Valbenazine is a selective vesicular monoamine transporter inhibitor that reduces the severity of abnormal involuntary movements in tardive dyskinesia. Adverse effects include sleepiness and QT prolongation. It is contraindicated with congenital long QT syndrome or with abnormal heartbeats associated with a prolonged QT interval. It should be used with caution for people who drive or operate heavy machinery or do other dangerous activities until it is known how the drug affects them. The first-generation antipsychotics cause anticholinergic ACH side effects by blocking muscarinic cholinergic receptors. Anticholinergic side effects include urinary retention, dilated pupils, constipation, reduced visual accommodation, blurred near vision, tachycardia, dry mucous membranes, reduced peristalsis, rarely leading to paralytic ileus and risk of bowel obstruction, and cognitive impairment. Taking multiple medications with ACH side effects increases the risk of anticholinergic toxicity, covered later in this chapter. In general, FGAs have strong EPS potential or strong anticholinergic potential. That is, when one side effect is prominent, the other is not. Other side effects of FGAs. Other side effects of FGAs include sedation, orthostatic hypotension, lowered seizure threshold leading to seizures, photosensitivity, cataracts or other visual changes. With chlorpromazine, Thorazine, and thioridazine, Mellaril, and increased release of prolactin, hyperprolactinemia, which can result in sexual dysfunction, impotence, anorgasmia, impaired ejaculation, galactorrhea, flow of fluid from the breasts, amenorrhea, and gynecomastia. Weight gain can be more than 50 pounds per year, causing significant psychological distress and increasing the risk of cardiovascular disorders and diabetes. Some side effects, such as sedation, occur initially but improve thereafter. Potentially dangerous side effects are infrequent but include anticholinergic toxicity, neuroleptic malignant syndrome, and prolongation of the QT interval, all discussed later in this section. Note that side effects that are not addressed increase the risk of non-adherence to treatment. Some have noted possible neurotoxicity in haloperidol and perhaps other FGAs as well, and haloperidol may cause a form of encephalopathy if combined with lithium carbonate. Nursing care for common or potentially dangerous side effects is located in Table 12.6. Second-generation antipsychotics. SGAs include drugs such as clozapine, Clozaril, risperidone, Risperdal, olanzapine, Zyprexa, quetiapine, Seroquel, and ziprasidone, Geodon. They antagonize D2 receptors, as do FGAs, but also bind to serotonin receptors as well. They're often chosen as first-line antipsychotics because they are equally effective for positive symptoms and also help negative symptoms. Side effects of second-generation antipsychotics. Like FGAs, SGAs can cause sedation, sexual dysfunction, seizures, and increased mortality in elderly individuals with dementia. However, most SGAs are less likely to cause tardive dyskinesia or significant EPS. Although they have the same potential side effects as the FGAs, SGA side effects are usually fewer, milder, and better tolerated. When the first SGA, clozapine or Clozaril, was approved in 1989, it produced dramatic improvement in some patients whose disorder had been resistant to FGAs and helped improve negative symptoms as well. Unfortunately, clozapine causes agranulocytosis in 0.5% to 1% of those who take it. As a result, patients taking clozapine must have neutrophil monitoring, discussed later. Clozaril can also cause myocarditis and life-threatening bowel emergencies. Due to these serious problems, clozapine use declined in the United States, and many clinicians reserve its use for patients who do not respond adequately to other antipsychotics. However, it is one of the few drugs that have Food and Drug Administration approval for the treatment of suicidality in schizophrenias. All SGAs carry a risk of metabolic syndrome, which includes weight gain, especially in the abdominal area, dyslipidemia, increased blood glucose, and insulin resistance. This metabolic syndrome is a significant concern and increases the risk of diabetes, certain cancers, hypertension, and cardiovascular disease, making its prevention an important role for nurses. Some SGAs also have antidepressant properties and are FDA approved for adjunctive use in the treatment of major depressive disorder. As with all antidepressants, they carry a theoretical risk of increased suicidality, particularly in adolescents. Other potentially dangerous SGA side effects include anticholinergic toxicity, neuroleptic malignant syndrome, and prolongation of the QT interval, all discussed later in this section. A subset of the SGAs is sometimes referred to as third-generation antipsychotics. These drugs are aripiprazole, Abilify, brexpiprazole, Rexulti, and cariprazine, Vraylar. They can be described as dopamine system stabilizers that act by reducing dopamine activity in some brain regions while increasing it in others. Aripiprazole and brexpiprazole act as D2 partial agonists, meaning they attach to D2 receptor without fully activating it, reducing the effective level of dopamine activity. Cariprazine acts as a partial agonist more on D3 than D2 receptors, which may help improve cognitive symptoms. Additional information about antipsychotics can be found in Tables 12.4 and 12.5. Table 12.6 describes common antipsychotic side effects and related nursing care. Dangerous antipsychotic side effects. Nurses need to know about some rare but serious and potentially fatal effects of antipsychotic drugs, including anticholinergic toxicity, neuroleptic malignant syndrome, and agranulocytosis. Nurses in psychiatry, primary care, and emergency services need to be aware of and monitor for the early signs and symptoms of these side effects. Patients and their families should be taught how to recognize and respond to dangerous side effects. More information in nursing care for these side effects is included in Table 12.6. Anticholinergic toxicity is a potentially life-threatening medical emergency caused by antipsychotics or other medications with anticholinergic effects, including many anti-Parkinsonian drugs. Older adults and those on multiple anticholinergic drugs are at greater risk. Symptoms include autonomic nervous system instability and delirium with altered mental status. Mental status changes can include hallucinations and may be mistaken for a worsening of the patient's psychosis, so people whose psychosis is inexplicably worsening should be immediately evaluated for possible anticholinergic toxicity. Neuroleptic malignant syndrome, NMS, occurs in about 0.2% to 1% of patients who have taken first-generation antipsychotics and is characterized by reduced consciousness and responsiveness, increased muscle tone, generalized muscular rigidity, and autonomic dysfunction. Although less likely, NMS can also occur with second-generation antipsychotics. Caused by excessive dopamine receptor blockade, NMS is a life-threatening medical emergency that is fatal in up to 10% of cases. It usually occurs early in therapy, but has also occurred 20 years into treatment. Early detection, discontinuation of the antipsychotic, management of fluid balance, temperature reduction, and monitoring for complications such as deep vein thrombosis and rhabdomyolysis, protein in the blood from muscle breakdown, which can cause organ failure, are essential. Agranulocytosis, while most associated with clozapine, Clozaril, is possible with most other antipsychotics as well. Neutropenia can also develop and can be fatal. Monitoring for neutropenia is done as part of the complete blood count through an absolute neutrophil count, or ANC. Symptoms of agranulocytosis include signs of infection, e.g. fever, chills, sore throats, or increased susceptibility to infection. Some individuals have lower normal levels of ANC. It is referred to as benign ethnic neutropenia, BEN. Among these people are those from African descent, about 25% to 50%, some Middle Eastern groups, and other non-Caucasians with darker skin. They are not at greater risk for developing agranulocytosis, but should have a baseline ANC before starting clozapine. Prolongation of the QT interval may contribute to sudden death of unknown origin that occasionally occurs in individuals with schizophrenia. SGAs, quetiapine, Seroquel, risperidone, Risperdal, and ziprasidone, Geodon, can prolong the QT interval. FGAs, chlorpromazine, Thorazine, haloperidol, Haldol, and thioridazine, Mellaril, have also been implicated in this cardiac emergency. Electrocardiograms should evaluate all people for existing QT prolongation, which magnifies the risk for medication-related prolongation, before being started on any antipsychotic. Liver impairment may also occur during antipsychotic therapy, particularly with FGAs. SGAs also lead to serum enzyme elevations, but rarely with injury or jaundice. Liver impairment usually occurs in the first weeks of therapy. This makes monitoring of liver function values essential. Signs of liver problems include yellowish skin and eyes, abdominal pain, ascites, vomiting, swelling in lower extremities, dark urine, pale or tar-colored stool, and easy bruising. The patient may complain of itchy skin, chronic fatigue, nausea, and loss of appetite. Disorders co-occurring with schizophrenia should be actively treated. Depression is common in schizophrenia and is typically treated with antidepressants and other interventions. See Chapter 14. Antidepressants and mood-stabilizing agents may be needed for mood symptoms in schizoaffective disorder. Benzodiazepines, e.g. lorazepam, Ativan, can reduce agitation and anxiety, which can worsen other symptoms and is quite common in schizophrenia. It can help lessen positive and negative symptoms. Advanced practice interventions. Services that may be provided by advanced practice registered nurses include individual and group psychotherapy, e.g. CBT, psychoeducation, medication prescription and monitoring, health assessment, and family therapy. Cognitive deficits can be addressed with cognitive remediation therapy, which teaches recall, attentional, and other skills to increase the patient's ability to function and maximize ultimate quality of life. While these are advanced practice roles, components of some, such as helping patients identify and correct distortions in thinking, can also be implemented by any nurse. Family therapy is an important advanced practice role. Families often endure considerable distress related to living with individuals who have acute and residual symptoms of schizophrenia, particularly if they are the direct caregivers or the patients become abusive. They may not know how to help their loved ones with schizophrenia. Families can become isolated from their peers, communities, and support systems due to the stigma of mental illness and shame they may feel. In family therapy sessions, fears, faulty communication patterns, and distortions are identified. Communication and problem-solving skills are taught, healthier alternatives to conflict are explored, and guilt and anxiety can be lessened. Family therapy in groups such as NAMI and the Schizophrenia and Related Disorders Alliance of America provide support, education, and opportunities to vent one's frustrations. This helps make families full partners in the treatment process, helps them find better ways to solve problems and reduce conflict, and improves the quality of life for the patient and family. This combined approach of family therapy and support groups recognizes that families are secondary victims of a biological illness, hence the name secondary consumers for significant others, and carry a heavy burden as caregivers. This example shows how one family came to understand schizophrenia and learn how to help their loved ones. I went to the group therapy session. We all shared what it was like for us dealing with the illness. Then my daughter and others there with schizophrenia talked about what it was like for them, how it made it hard for them to take a shower or to listen and focus when they are hearing voices or having upsetting thoughts. I really didn't understand it before. I used to think my daughter was just being lazy. I didn't know it was her illness. I thought she could make the symptoms stop if she tried hard enough. I felt so bad for those times I yelled at her or pressured her to get a job before she was ready. We all had a good cry and everyone agreed to talk more and to try harder to understand the other person. Evaluation. Patients' progress should be reevaluated regularly and treatment adjusted when needed. Staff, patents, and family. There are so many errors in this book. Staff, patients, and families should remember that progress may occur erratically or slowly, and that gains may be small and difficult to see, even after the patient's symptoms seem to have improved considerably to others. Inside, the patient may still be recovering. As with other serious illnesses, full recovery can take months. Setting small goals makes it easier to identify progress that may occur in small increments. Active staff involvement and interest in the patient's progress communicates concern, and caring helps the patient to maximize progress. Promote treatment adherence and reduces feelings of helplessness. Involving the patient collaboratively as a true partner in his or her care is consistent with the recovery model that increases patient trust, motivation, and buy-in. Staff must remain objective, actively engage with the patient, and stay abreast of developing treatments to ensure that care is evidence-based and of the highest quality. Quality improvement. Incorporating evidence-based treatment, creatively developing and incorporating treatment innovations, and examining outcomes data can improve patient care and outcomes. Professional organizations have developed standards of care and guidelines for the treatment of schizophrenia, incorporating evidence-based practices that include effective affordable medications titrated to effective dosages, using second-generation antipsychotics for individuals with first episode psychosis or prominent negative symptoms, monitoring and treating for risk of suicide, monitoring and treating for concurrent substance use disorders, preventing metabolic side effects, assessment and management of concurrent medical disorders, monitoring for and promptly managing dangerous medication side effects, monitoring for promptly managing other medication side effects, monitoring for and promptly managing fall and choking risk, involving the patient in active case management services to ensure coordination of care and prevent falling through the cracks, involving the patient in cognitive remediation programs and other activities that build cognitive skills, and promoting involvement in self-help and support groups, e.g. NAMI.org, and in other activities and resources consistent with the recovery model. And that is it. That is it for Chapter 12.